Okay, hello everyone. I'm Dr. Mindaugas, and today I will present my borders technique with you in this masterclass. Please let me know in the chat if you hear the sound and the video is okay, so I can start with the presentation. All right, everything looks good, so let's start. So in the borders technique, what's the most important thing for me is predictability. So every time I do a filling, I can be pretty sure that if I have the right amount of time left for the patient, I can get natural looking results. And I can make it the same for all of my patients. Because with the technique I'm going to introduce to you today, I have a special workflow and special set of rules that help me get the results I want very predictably and I guess relatively fast. So all of my patients can enjoy having the restorations, direct restorations of their posterior teeth that look like a part of the tooth, actually. One of the most common questions I get is how much time do I have to spend to make the restorations look good? Because one of the common myths is that it takes too long. It's impossible to be on time and make a good looking restoration, that you have to spend hours or I don't know, almost an hour for one filling. That's almost impossible in any busy daily practice. And for this, I just had a case yesterday. If you follow the RIPE group on Facebook, you might have seen me posting it. But I had this case, this patient was booked for 2 hours because I knew I might end up with a big MOD cavity on the lower first molar. I knew I might run into trouble and have a class 2 defect on the premolar as well. We were thinking that we might need to change the old filling on the second molar as well. So usually if I can, I try to book more time for the patient. It's not always possible. But even here, when I started 8 o'clock sharp in the morning, so the patient is already numbed. I have wooden wedges placed, and I have a problem in between the molar and the premolar. So I have an old filling on the molar that is causing a food to get stuck there and making some discomfort for the patient. And also the patient is starting to feel some sensitivity there. So I start removing all filling material, and as you can see down on the left side, the right side of the screen, there is a little timer. So I just wrote down the time each picture was taken. So here, if I'm not mistaken, I'm already half an hour into the procedure and the filling is still not removed. Why was that? Well, it was just one of those days that I couldn't get the patient numb. So I made the nerve block. The patient was still feeling something. I've made some infiltration, both from the buccal and the lingual. It seemed like it got better, but still the patient would start to flinch when I start to drill. So I started removing the old filling on the second molar, and the patient was not feeling anything until I got deeper. I found some soft dentin there. And as soon as I got there, the patient felt sensitivity again. So I made another block. I made another infiltration. And almost an hour into the procedure, I only managed to get the patient numb. So I guess we all been there in a situation like this. When we plan for a very easy going procedure, we leave ourselves extra time to make the restoration as good looking as possible and to have a relaxed workflow. But now half of the procedure I've spent only to get the patient numb and only to remove the old dentistry, not even talking about the caries. So another 9 minutes, I already have the restoration removed and the tooth ready for bonding. So I have it sandblasted, I have my matrix in, another 6 or 5 minutes to rebuild the proximal wall and to bond all the tooth, and then of course rebuild the dentin. Few more minutes to rebuild the lingual cusps, since I know I might be running late with this patient, even though I had 2 hours booked for free fillings, I'm not going to do anything crazy here. So just basic primary anatomy. And to do a pretty big MO filling, I only spent 15 minutes. Is it long? Is it fast? I guess it depends on your practice. I guess it depends on your experience, on your pace. But for me, 15 minutes to get a nice looking occlusal surface just with the primary anatomy is more than enough. And I consider it pretty good. I could make it faster by making just a flat filling, but I might lose some time having to adjust that flat filling. However, like in this case, what you'll see in the end, the adjustments don't take me that long if I place the anatomy in the right places. So I move on to the premolar another 5 or 6 minutes to adapt the matrix, to choose the right matrix, to wedge, to put on the ring. Then I take this picture. I noticed that I could clean the cavity a bit better. There's some still composite remnants there, some decay possibly in the previous groove. So I take care of those and I make the restoration. Again, I spent 15 minutes for this case. Why was it this long? Because the cavity was smaller? Well, basically, if you have smaller cavity on the smaller tooth, it becomes more difficult if you want to try and add more anatomy. So I thought that since I was pretty quick with the first molar, I might spend just a little bit extra time on the premolar and try to make secondary anatomy here. And I did. I lost extra 5 minutes or so, but the tooth looks like a tooth now, and this makes me happy. And when I'm happy, well, I like the procedure more, so I can be, I don't know, better at it maybe. And we have left only the second molar. So a standard class 1 cavity would be, I don't know, 5-minute job just to make a flat filling here. I opted to go and try to recreate at least the basic primary anatomy here to cover the wear facets and some mesial pit here. I didn't explore it too deep here, just because I sandblasted it and it didn't go down too fast. So I just thought that I have quite a lot of enamel around, so I can just bond it in. And I don't see any shadowing from the distal part of the cavity, so it should be good. Anyway, I rebuilt the anatomy. I'm not exactly proud on how it turned out, and I know where I made a mistake. So basically, I have a certain sequence how I rebuilt my teeth. So you saw on the first molar, I rebuilt my linguals first because those cusps are easy. They're very simple. The shapes are simple. Here, I started from the distal buccal because I thought that it's damaged the least, and I have quite a lot of information where it should be. But because of that, my anatomy got a little bit skewed, and that's why I had to spend a bit more time trying to make it look better and trying to correct my mistakes. So the final is not perfect, and it took me as long as to recreate both of the other teeth, even though the cavity was very small. So not always small cavities are easier. Sometimes combined with a difficult axis, it can be even harder. So I have the teeth restored. I have 10 minutes left to finish with this patient, and I have the next one coming in. So I pre-polish my restorations. So I don't need to polish them again when I remove the rubber dam. I check the occlusion, and here you can see that I don't have to remove a lot, and most of the occlusal spots are where they should be, and I only need to remove just a few bits, and it will only take me a few minutes until the patient feels comfortable. You can see some excess composite on the lingual of the premolar and the molar. That's just something I noted in my notes, and I'll take care the next time the patient comes the next month. Basically, meaning both me and the patient, were pretty tired after this long procedure. When you're tired and it's the end of the procedure, it's pretty hard to notice the small details, and that's where photography really helps, so you can know what to check next time the patient comes, or you can recall the patient if there's no appointments planned. So all of this was possible, so filling free of the cavities in less than an hour was possible just because I followed my borders technique. So what's the borders technique and how does it help me? Well, basically, it's taking any occlusal surface and deconstructing it. So what do I mean by deconstructing? Trying to understand how the occlusal surface is built so I can recreate it in my composite. Because when we look at the occlusal surface, occlusal anatomies, when we talk with our technicians, when we read books, we look at really beautifully carved composites or ceramics, we think that, oh, this occlusal surface is so beautiful, but at the same time, it's so complicated. And we have this idea that it's so complicated, it actually limits our ability to reconstruct it because we think it's too complicated that we can make it in our daily practice. And there are a lot of ways we can look at the teeth and try to understand it. So we can look at the grooves and try to remember the shapes the grooves are making. I don't know whether we see a Mercedes sign there or a peace sign there, maybe some elk horns on the premolars. And it's all good. And it's always nice to have some sort of associations to remind ourselves what kind of shapes are we recreating. But when we look at the occlusal surface through the prism of grooves, we kind of force ourselves to take a piece of composite, put it in the cavity, and then try to carve the anatomy with some sort of sharp instrument. As many times I've tried that, I was never happy with the result. One thing, composite is not very good material to carve, especially when it's soft. If you try to carve composite when it's already set, then you're very limited to what kind of shape and what kind of surface texture you'll get from your burrs. And trying to be very precise and to have these nice organic grooves with your burrs, it's almost impossible because the burrs are spinning fast, they leave pretty straight lines, and I was never able to recreate that with the burrs. If we use the bulk approach, so we fill all of the occlusal surface with the bulk material and try to carve it while the composite is still soft, well, that might work, but again, the composite is not very good material to draw on, and it's quite sticky. And when you try to manipulate all of the occlusal surface at the same time, you push on the distal and the mesial moves as well. So it's very hard to control all of the structures. And then we fall back to the idea that it's complex and try to recreate a very complex structure in one go is very difficult and it's very taxing. So not knowing what kind of shapes grooves are making is good, but it's not the best approach to the occlusal anatomy, at least in my view. We can try to look at the occlusal surface as part of the function. So there's a very nice concept I learned from a dental technician from Hungary, János Mako. So the occlusal compass. Basically, the occlusal compass is just a bunch of lines showing where the antagonist is moving during the function. So, for example, here, the lower molar, one of the lower molar cusps, go in either of the directions during protrusion, lateral movement, lateral protrusion, and medial protrusion. And what we can see that most of the lines coincide with the grooves. So we're going back to the grooves, but now we're not trying to remember what kind of shapes in the occlusal surface we have, but more why we have those shapes in the exact places. So now we can see that the grooves are mainly where the antagonist will be moving in function. That's a very important concept to understand. If we're trying to recreate the occlusal surface, we've all been there. You make a beautiful filling, patient bites down, you have to grind it all down, and you're left with just a flat filling with no anatomy there, and you get frustrated. So sometimes the problem is that you just overbuilt your composite increments. So we have your cusp tip here, and instead of having a slope towards the center of the tooth with your composite, you just overbuild everything. So that's a common mistake. It's just a matter of handling your composite increments. And it's easy to correct when you know the problem. You just have to check the excess all of the time. The another problem is creating your own anatomy in the occlusal surface and placing the grooves where they shouldn't be. And at the same time, if you move the grooves, the high spots of the occlusal surface, so all the ridges of the cusps, move as well. So it might be that you've just made a ridge where the groove should be. So instead of having space for the antagonist to move, you have a high spot that interferes with the movement. So it's very important to understand that if we're trying to recreate the anatomy, and it's very important to understand the word recreate. So we're not creating anything new. We're just trying to replicate what was there in the first place. So we're trying to recreate the occlusal surface. We have to know where the cusps should be and where the grooves should be. And for me to understand that and to get the idea of where the cusp should be and where the grooves should be, well, basically just to understand the occlusal surface, the easiest approach was just to deconstruct the tooth into the elements the tooth is constructed from, so the cusps. And when I have the tooth deconstructed in the cusps, suddenly I don't have this one single complex structure. I have one single complex structure combined of 4, 5, 6 structures that are quite simple. And it doesn't take any artistic skill for you to make the occlusal anatomy difficult when you only have to make one increment of composite that looks like a triangle, and it just has to fit in the occlusal surface. So if we have to divide the upper first molar, we have the distal buccal cusp, we have the distal palatal cusp, distal buccal cusp, mesiobuccal cusp, mesiopalatal cusp, and 2 additional distal and mesial cusps. So all I have to know about the upper first molar is that it has 4 primary cusps. We might have 2 additional cusps. We can join them to any of the cusp if we're really if we really have to be faster about our procedure. But basically, if we'll make 4 increments of composites, and each of those increments will be in the right place, replicating that one cusp, the occlusal surface will be quite easy because we'll only have to make 4 steps and focus only on one cusp at a time. And trying to analyze the shapes of the cusp, we'll notice that the shapes are pretty easy, and the reference points that will guide where those shapes should follow are quite easy as well. So when I have the construction of the occlusal surface, and when I understand that each of the cusp has to be in the right place, otherwise I might have some problems with the occlusion that is too high, or some interferences during the movements that again will mean that I'll have to adjust a lot. I thought that each cusp could represent a different country or a different state. And the grooves in between the cusps, well, actually are the borders of the cusps. So we have this sort of map inside our brain for each of the molar and premolar. And the main idea with the borders technique is that you have to respect the borders, just like in real life, in geography, or in politics, geopolitics. No country wants to invade the other country regarding the borders. If we cross the border where we shouldn't allow to do that, well, we create some problems. The same happens with the occlusal anatomy. If we're doing a sequential build-up technique or cusp by cusp technique or whatever it's called, we're just taking a piece of composite, putting it inside the occlusal surface and shaping so it becomes part of the tooth. We have to be very careful to make the borders of our cusp increment exactly where the grooves will be. So we have to make our composite increment exactly the replication of that one cusp we're working on. And it's quite easy because, like I said, the cusps are pretty easy in shapes. They're quite simple. And when we have to focus only on one cusp at a time, it becomes quite easy to control the complex structure because we don't have to think about all the complex structure in one go. So that, I guess, is the main idea for me, to understand that each cusp has the very precise place in the occlusal surface. And if I'm building, for example, upper first molar, and I'm building up the distal palatal cusp, that is the smallest cusp in the occlusal surface, and I make it half the width of the mesiodistal dimension of the tooth, I won't have enough space for my mesiopalatal cusp that should be the widest cusp in the occlusal surface. So suddenly I'll have 2 equally sized palatal cusps, and it won't look good because we don't have that in nature. We don't have equal-sized palatal cusps on the upper molars. We have the very dominant mesiopalatal cusp and a very little distal palatal cusp, and we have to respect that. And to respect that, we just need to deconstruct the deep tooth and understand where the border of each of the cusp is. So just to give you the idea of how you can deconstruct the occlusal surfaces on your own and what kind of thought process I had when I developed the technique, or I just tried to systemize the technique. It's actually not something I developed on my own or I created. It just, I guess, the collection of the rules of the anatomy. Those are universal. Those were created by nature. And just trying to think of composite application sequence, that's quite easy. And again, I've got quite a lot of inspiration from many great dentists from around the world I had the privilege to learn from. So for example, lower second molar, we have 4 cusps: the mesiolingual, distolingual, mesiobuccal, and the distal buccal cusp. So 4 cusps. We find the center of the occlusal surface. Well, it's in the center, so that's easy to find. We find the middle points of both mesial, distal, lingual, and buccal surfaces. We connect those middle points. Of course, they'll connect and join in the center because that's where the center is. And that's how we find the center, just dividing some object in a few places and trying to find where the lines will meet. And we will notice that the white lines we have here are pretty much in the same places where the borders of the cusps are. So all I have to think when I'm building up lower second molar is trying to put my composite increment exactly in between the lines. Then my grooves will be in the right place. Then I'll have right proportions and the tooth will look like a tooth. So instead of trying to remember the complex fissure pattern, I'll just try to make 4 equally sized cusps that will meet in the center. If I have some extra time or I want to be more careful with my layering, I'll take note that the mesiobuccal cusp is not touching the distal lingual cusp. So I will take care and make that in my composite as well. It will look more lively. Or if I have more time, I'll take care and try to make not flat composite increments for my cusps, but I'll try to make the central lobes of each of the cusps, and the direction of the central lobes should be taken care of as well. So they're not pointed towards the center of the tooth. That's a very common mistake. I've made that one a lot of the times. And as we see in the model here, the central lobes are actually joining together. So basically one central lobe is pointed towards the opposing cusp's central lobe or opposing cusp tip. So if we make the borders in the right place and we make the central lobes in the right place, we'll have a very nice looking filling, and we'll have to adjust very, very minimally because we'll have the right high spots where they should be. So the central lobes will be in the right place, and we have the low spots where they should be as well, where the fissures are. So this one is very easy, and the next patient you'll have with the lower second molar, just try to make 4 equally sized cusps that divide the occlusal surface in quarters, and you'll see that it will look pretty good. And that's why I showed you the lower second molar, because from the molars, it's the most easy one to recreate. And it's important to understand that if you want to learn something complex like the occlusal surface, you have to learn, you have to start with the basics. So the basics are the primary anatomy. If you want to learn, for example, one of the molars or premolars, at first try to memorize how many cusps they have and where are the reference points that will help you guide you in the occlusal surface to find the place for that cusp. Only when you have skill and confidence with the primary anatomy, you can start noticing where the central lobes are and where they should, what's the direction of the central lobe. After that, putting in the secondary anatomy in your occlusal fillings will be quite easy because you'll have the borders and you have the high spots, so the central lobes, and the secondary anatomy, so the distal and distal and mesial marginal ridges are in between the primary, in between the borders and the central lobes. So it's very easy to find and it's very easy to understand it. And only then, I guess, we can talk about the shade. So regarding the posterior fillings, shade is something of the least importance. So if you followed any of my work, in the last 5 years, I guess I only used dentin and enamel stratification for posterior tooth once, just to see if I have a better looking filling. And honestly, I didn't. So I stick to one shade for all of the occlusal surface. If I want some depth, I just add some chromatic dentin underneath following Gianfranco Politano's trilaminar layering technique. The same sequence for learning should be applied to your patients as well. So when you're in a rush, there's no need to try and make the secondary anatomy because you'll just won't have the time for it. You have to start with the primary anatomy when learning. You have to create a primary anatomy where you're short on time, or you're doing something temporary maybe, like in this case, huge filling, limited amount of time. Indirect should be the option here, but the patient is hesitant for it. So it's just a primary anatomy because it's like a long-term temporary. However, if I can book extra time, I can make the restoration that makes me happy and the restoration that looks beautiful. Or maybe, I don't know, you have a patient that is your family or maybe a colleague that can appreciate your effort making the secondary anatomy, then why not make it and make the tooth look, well, more beautiful. The problem with the secondary anatomy is when you don't really know what you're doing, but you want to make something complex, you get a result like this. So this is a case from maybe 4 years ago. I booked extra time. I made all these secondary anatomy, the secondary grooves, I stained them, but the tooth looks off. And it looks off because, well, the primary anatomy is quite good. I have 4 cusps and the distribution of the cusps are quite good. But the central lobes are all pointed towards the center. And that's not the case with the lower molars. And suddenly the tooth doesn't look like a tooth for me when I know that rule. So try not to be too complex with your fillings from the beginning and learn the very basics first. And when your confidence builds up, then try to do something more complex. Okay, so how do you apply the borders technique? How does it actually work? Soon we'll show you a video of the upper first molar so you can see all the steps. But just to give you the idea of how it happens in the daily practice. So this is an older case. It's very rewarding to replace the old amalgam fillings because you can have a very strong before and after imagery here. But when I remove the amalgam, I just had this map in my mind. I know where the center of the occlusal surface is. I don't even have to have any reference points from on the outside of the occlusal surface because it's already there. I have some stained grooves, the beginning of stained grooves that are just showing me that's the wing point where the division between your cusp should be, where the groove will run. And I know that the lingual groove will go all the way to the center. I know that the groove in between the central cusp and the mesiobuccal cusp doesn't go all the way to the center, so I have more space for the central cusp. And just knowing these few rules, I can connect everything. And every time I make a new increment, that increment has to fall in between these, some of these 2 white lines. And then the end result is pretty natural looking filling. So this is quite easy. You just have to practice. And to understand the occlusal anatomy, to find all the reference points or to find everything that will help you in your daily practice, you can do it on your own pretty easily. You can observe the pictures of natural looking fillings, sorry, not fillings, of natural looking teeth. Don't learn from the fillings, don't learn from the crowns, because the crowns and the fillings are created by dentists and dental technicians, by humans, and humans are not perfect. So if you want to learn something, learn from the nature. That's the best starting point. And sometimes you'll notice that the anatomies are quite simple. For example, this premolar here, it's so simple. There's a saying, simplicity is the ultimate sophistication. And this works so beautifully here. Most of the times I ended up with weird looking premolars is when I tried to create too much of the anatomy. So instead of making few cusps and maybe just 1 or 2 secondary cusps, you end up having, I don't know, 5, 6 increments, and the filling looks awful because you create something that shouldn't be there. So learning from the nature is, I guess, the best starting point. But sometimes pictures are quite hard to learn from. So you can ask your lab for some plaster models. Any beautiful teeth models, they'll have some reference models they have from their study times or from some courses with very detailed anatomy. You can learn from those. If we end up with in another lockdown down the road in these crazy times, and you don't have the chance to get any physical information, well, we'll now live in the digital world. Almost all of the labs will have digital models. Just ask for some nice digital models of nice teeth. Both Mac and Windows have now built-in STL viewers, so you can just move the models around, scale them, analyze each of the cusps, what kind of structures you have there, where are the line angles, where are the central lobes, where are the marginal ridges. And then when you're back on track in your work, it will be so much easier to recreate something when you actually know how it should look like. And just for you to get the better idea how the borders technique looks like, or how to take the knowledge of the reference points and how to make it into the filling, I want to show you a video. And let me just change the screen. And during the video, you'll show the sequence of cusp buildup for the upper first molar, and we'll continue after it. So in this video, we'll cover the occlusal buildup of upper first molar, and again, we'll begin with leveling off the cavity with the dentin layer. I'll add some flowable at the very bottom, not to introduce any air bubbles, and I'll use the paste composite. So for the secondary anatomy, which we'll try to recreate here in this molar, it's easier to use the paste composite because you have more control to make the convex shape of it. So we can make it deeper in the center of the tooth, and we can add more support in the periphery of the cavity, so towards the outline of our prep, where we'll have thin and delicate structures of the occlusal surface, like the marginal ridges. So I just remove a bit of the excess, and that excess is actually flowable. I put on the very bottom, so it actually did its job and spread all over, but make my job a bit harder because now I have to clean off all the flowable, not to leave any chroma, unwanted chroma, in between my cavity prep and my future composite, and at the same time, depending on the flowable you use, not to leave less filled composite material on the occlusal surface. So after cleaning it out and having built my dentin layer to the height I like, I will cure it. And just like with the upper second molar, we'll have the same idea of the build-up sequence, but we'll just divide it into more steps so we can focus on the delicate structures of each of the cusp, making it possible for us to recreate the secondary anatomy as well. So we start with the distal segment, but instead of doing one go, we'll do it in 3 increments. I know it's a bit confusing at the beginning, but once you repeat it for a while and after you compare what you're doing with the reference models you have, you will understand why it's important to divide it into 3 steps. So in the first step, we create only the distal palatal cusp. And distal palatal cusps should be the smallest of all. And the boundary, the start of the border on the palatal side, usually it's already in the tooth structure. Most of the times you'll have a very nice idea where to start. If you don't, usually it's not directly in the middle, it's slightly shifted towards the distal. So divide the palatal surface in the middle, go slightly to the distal, you'll have a starting point for your border of the distal palatal cusp. The endpoint of the border is exactly in the middle of your distal marginal ridge of the tooth. So we create a pretty much straight line here, and just before curing, think about where your transverse ridge will be going. So it will start here, it will run down parallel to the distal wall, it will make a turn and go towards the cusp tip here. So here I have a pretty enough space for my future transverse ridge. So I'm not invading the space with my distal palatal cusp too much, and that's all I want to do and all I need to think about while making this increment happen here. Now I'll add a small increment for the distal ridge or the distal cusp. So it's actually not part of any cusp, it's just additional cusp of the upper molars, and you have to add just a teeny tiny bit so it creates this nice triangular shaped ridge that's not too long. It doesn't extend further than our border of distal palatal cusp, and it will follow this shape of the crescent moon we did here in one go. But instead we leave the secondary groove in between the increments, and this way the occlusal anatomy will look nicer. And the last bit of our first distal segment is the distal marginal ridge of the distal buccal cusp, and this is what actually makes the distal buccal cusp look very lively and nice. But you can also make a lot of mistakes by making this structure here. So it's very important to follow this crescent moon shape, and especially here near the cusp tip of the distal buccal cusp. So you really have to be careful not to extend your anatomy here towards the mesial too much, because as soon as your distal marginal ridge of the distal buccal cusp will become too wide, suddenly you won't have space for your central part of the cusp, so the central lobe. And if you won't have enough space for your central lobe will shift towards the center of the tooth, and your transverse ridge will shift towards the center of the tooth. Not only your tooth will look funny, you'll have to grind it all down because you'll place the highest part of the tooth towards the center of the tooth, which should be the deepest part of the tooth. So be careful by making this distal anatomy here. And think about the crescent moon shape. Make a groove in between these two cusps. Remove the excess. You don't have to make any ridges inside this increment. And just before curing, I'll visualize where my central lobe will be and whether I'll have enough space or I can correct it by removing some from the distal buccal cusps, distal marginal ridge. Okay, now switch to the distal buccal cusp, and again we'll have 3 increments here. So just to make it easier for you to visualize here, I'll make a small dent here in the center of the occlusal surface. And now let's think where our distal bit should be. So remember the rule: if we make a line here and go slightly distal than the tip of the distal buccal cusp and slightly palatal than our central bit is. So we'll end up having a point here, and this will be our distal pit somewhere here. We just have to eyeball it, doesn't have to be very precise. Here we have a boundary of our distal buccal cusp here, which is the palatal border, and here we have a mesial border here by connecting the middle of the buccal surface with the center of the occlusal surface. But while making the central lobe, we'll only take care about the palatal border now, because we'll have to leave enough space for our secondary anatomy on the mesial side. So now it's very important to make a ridge here, because we want to make the transverse ridge, and the transverse ridge is created by joining the central lobe of the distal buccal cusp with the distal wall of the mesiopalatal cusp. So try not to ruin the distal segment you just created, so leave the fissures there. At the same time, work on your inclination of the cusp. So you see my brush is working from the sides and never just in the middle of the increment, and I'm just closing the distance in between my increment and the remaining anatomy, and I'm still trying to make it more clear where my central lobe is. So now let's take a small step back and try to chase the reflection, and I can see it running pretty nicely from the cusp tip towards pretty parallel to our distal marginal ridge of the tooth. So this is covered. I'll just work on the fissures here a bit more. If I want to make the fissures more clear, I can take my sharp instrument, lean it against the structure I already made, so I have more control. I don't have to draw the fissure inside the soft composite here, and I'll just take the brush and smooth it out just a little bit. Okay, so now we have a nice palatal border. It could even extend a bit more to the palatal. It doesn't really matter here with the distal buccal cusp because it will join with the mesiopalatal anyway. So having exact boundary is not that much important, but it's just a nice reference point so you don't overextend too much and don't make your life too hard. And we have enough space for our secondary anatomy here. And I guess it's a good time to replace my brush and to refix my model on my working table. Okay, so we can cure this increment now. And now, if we look at our distal buccal cusp, we need this nose-like extension towards the center. So I don't really have to add much, but it will look nicer if I have this defined structure. So depending on how much composite you had for your central lobe, most of the times it ends up being quite cylindrical, so you really have to add this nose-like shape and to make it very well defined. In this case, I will only have to add a little bit. Okay, so I just like we did with the lower first molar, I tried to add a little extension to the central lobe. So I really have to smooth this increment towards the remaining lobe, remaining tooth structure here, so I don't end up having some weird fissures running in between. And I'll just add a little marginal ridge on the mesial. So regarding the marginal ridges on the upper first molar, is you have to take care and look at the drawings from the handouts, or look at the reference models if you got the virtual hands-on component, and try to understand how big or small the secondary anatomy should be in that tooth. So for example, one of the biggest mistakes is making the secondary anatomy and making it completely wrong. So for example here, if I wouldn't have made this nose-like extension here, I would end up with a marginal ridge running all the way towards the center of the tooth. So it will look weird because it's not quite right. It's not really the story behind the distobuccal cusp here. So we have to know that the mesial marginal ridge here doesn't go all along the border, the mesial border of this cusp. It runs only about 2/3 of the length. And knowing this, and knowing the position of the nose, and knowing the inclination of the central lobe are the main things that are important if you want to make the occlusal anatomy of this tooth work or look natural. Now, another rule or another thing that will help you for the next step is knowing that the width of the distal marginal ridge of the mesiobuccal cusp is actually pretty much the same as of the marginal ridge we just did. So we have a nice reference point, and we know that this little marginal ridge is little. So it's even smaller, even shorter than the marginal ridge we just did for the distobuccal cusp. So even though we don't have an exact dimension measured in millimeters, just by making it slightly shorter, it will make it look natural and good. And of course we have to take care and make the fissure in between here. We can even make it deeper here because it's a primary fissure dividing the cusps. If we would make this increment too long, again, it will look weird, and even worse, we would lose the space for our central lobe. And the central lobe here, as you should know from the lecture part, is running from the cusp tip towards the occlusal center of the tooth. Let me just pack it in really good so I don't leave any gaps under it. And now we can start working on the inclination of the cusp and on the fissures. So now we're only working on the central lobe here, so we don't overextend to the palatal too much because we have to leave enough space for our mesiopalatal cusp and the central lobe of it. Okay, we leave the grooves here. And now what about this part, the mesial part of the mesiobuccal cusp? Where should the mesial marginal ridge be? How much space we should leave for it? Well, in these models, the mesial marginal ridge is almost already made, and it's here, and we would only have to add just a little bit composite here. So if you don't have the mesial wall and you just rebuild it and you have space, you can do that. In this case, I'll just move it out and leave just a little space for it, so you will know how to make it when the time comes. And we have a nice bean-shaped curved line central lobe running towards the center of the tooth. I can cure it. Now I can add the tiniest bit of composite to the mesial marginal ridge here. Make a small fissure. And cure it. And now the last bit is the mesial cusp, and it's actually not really the part of the mesiobuccal cusp, it's just a little cusp that runs in between the mesial cusps. And the shape it has is quite longish. It doesn't run all the way towards the center of the tooth, just ends up maybe half of the distance short. And we'll leave enough room for our mesiopalatal cusp. Okay, this looks pretty good. Again, in these models you can anticipate where the fissure should start and end, so it's a little late for us, especially while we are training. And the more fillings you do like this, practicing, the easier it will be working in the mouth. And now again we end up with having a last bit to do, is the mesiopalatal cusp. We'll make it in 3 steps. First we'll make the mesial marginal ridge here, then the central lobe here, then the distal marginal ridge and the distal wall, making the transverse ridge. So the mesial marginal ridge is a simple, quite flat filling, quite flat cusp, part of the cusp actually, and it runs pretty much at the same place where we just made our mesial cusp. So it's a small triangular shape, doesn't run all the way towards the center. It's quite flat, you don't want to make a high spots there because this is where the antagonist moves during some lateral, I guess, maybe medio-intrusive movements. Yeah. Looks okay. Now the central lobe. Central lobe runs from the cusp tip towards the center of the tooth, and we leave enough space for our distal part, so the transverse ridge. Remove the excess. Smooth it out. Now working from the sides more to make the ridge more distinguished. Take a step back. Check the ridge direction from the cusp tip towards the center of the occlusal surface. So looks pretty good. Just go once more over to make it smooth. And the very last bit, the distal wall. And the creating of the transverse ridge, or actually creating the last missing half of the transverse ridge. So I already have too much of the material here. I want to adapt it quite nicely towards the center, and I don't really have a really deep fissure here, so I just want to make it nice and smooth, round transition, and having a ridge running from the cusp tip here towards the cusp tip here. We have a bit of an incline here. And now it's a brush time. So we make it smooth. And that's it. If you want to check the position of the ridge, again, let's zoom out a bit. You can check from the palatal side. You see a little wall here. You see where the reflection is running. So it connects the cusp tips in a nice arched line. And even though we focused on the small little steps, the main idea, the main boundaries are still there, and that's why the tooth looks natural. So the last curing for the transverse ridge, and now the stain just to make it pop. Now another thing with the stain you can use if you are really confident on your occlusal buildup and the height, or for example you're rebuilding a tooth for a denture wearing patient on the opposite side, so you can adjust the denture if needed. So if you're really confident and you want to make your filling pop even more, and you will know that you won't touch your occlusal surface with any rotaries, well, maybe except the polishers afterwards, then you can use not only the stain for the fissures, but also some white stain for the cusp tips, or the ridges, or the secondary anatomy, just to make your filling pop a bit more. And I'll just show you how to make that. So even though most of the times it will lose the white bits quite soon on the occlusal surface, just for the pure aesthetics, or just to have a nice picture of your filling, it might be worth it. So we take some white stain and we run it over our ridges, emphasizing them a bit. Don't overdo that, be subtle, just redistribute it by placing them closer towards the center. It will have a nice contrast with the fissure stain, and I'll just take the brush and make it uneven, wipe most of it away. So this is like an extra minute of your work, purely for the pictures, purely for self-satisfaction. It can be a nice thing to make your filling look just a little bit more natural, or just a bit more pop to the view. Part of what you just saw is actual footage from my virtual hands-on course we have on Right Global. And as a thank you for watching this masterclass, we have now $75 discount for the course for the next 44 hours for the participants of the course. So if you were thinking about it, this might be a very good chance for you to try and get it. And the main thing you'll get there is the same videos for all of the molars and premolars, descripted in the same manner, in the same sequence. Some will be described in the primary anatomy, some will be described in the secondary anatomy as well, more or less steps, so you can cover all of your posterior fillings, the occlusal surface of posterior fillings, and you can practice them. And the practice is the main thing that will help you understand the borders technique. So whether you'll take the course or you'll practice on your own, learning from the natural teeth and on the any drill teeth, or actually every patient you work with is the perfect place for you to practice, perfect chance for you to practice. But in some of my hands-on courses, the real live hands-on courses I'm having, sometimes I like to do this little exercise when I give the participants the same teeth, the same 3D printed models of both upper first and lower first molars, and ask them to fill them under some time pressure. So they fill them how they know, and sometimes the participants have no idea, or maybe they're stressed so much they end up with a filling that's just flat looking or don't have the nice anatomy. And by the end of the day, in the same hands, following actually the same sequence, so the virtual hands-on course is basically the same course I'm running live, just filmed through the scope, so the same steps, and the same participant can reproduce the same results. So it's just a matter of understanding where you put your composite, understanding of the basic morphology principles, and practicing a lot. So the virtual hands-on course can offer quite a lot of practice for you, and can offer the same 3D printed models I'm working on the videos. So you can actually follow along with your favorite composites to recreate the occlusal surface on your own and to get the better results. And you can practice further on the same models or on your patients or on some extracted teeth on your own, following the same principles. So I would like to thank all of you for joining me today. If you want to follow my works, you can follow me on Facebook or Instagram. I also have a few clinical videos, narrated clinical videos of live patients in RIBE Global. Also make sure to check all of the other teachers from RIBE Global for all of their procedures. It's a bunch of great clinicians sharing a lot of great stuff you can learn, and I learned a lot from them. And I guess we can jump to the question section, and I see that we have quite a lot of questions. If you have a question and you didn't ask it yet, just jump to Q&A section and write down your question. I'll be happy to stay as long as needed to answer all your questions here. Also, we have Dr. Lisa and Dr. Rahid here with us, and they'll help me answer the questions related to the virtual hands-on if you have any. So they both took the virtual course, so they can give you the insight from their perspective, what they've learned, or what problems they have solved, or anything you want to ask them about the course. I'll refer the questions for them. So I guess I'll put on my headphones so I can hear other participants if needed. And I guess we can jump straight to the questions. Let me just try. Stop the sharing and open up the questions panel. Okay, we have quite a lot of questions today, 47. Yeah. So the first one is from June. Sorry if I'll pronounce the name somehow differently. So the question is, some dentists cure the entire occlusal anatomy in a single increment. Some dentists carry out incremental centripetal techniques. Is shrinkage a big issue with composite if you use the snowplow technique? If so, is it the dent and resin stress or the residual stress between increments that we should worry more? Honestly, I'm not a very scientific kind of guy. I think I've used all of the techniques available. So I used bulk fill materials and cured huge increments. I tried to just cure occlusal increments step by step, just for a few seconds, and then cure the whole bunch in the end. But I use a cusp by cusp approach, mainly for convenience, so I can control each increment better. And at the same time, I can cure composite in different increments, so I have less shock of the composite shrinking stress, I guess. For the proximal wall, I use the snowplow technique or injection molding technique a la David Clark, just so I can get better contact. And whether I have a residual stress, I'm not sure, but I'm just trying to avoid having voids and layers in the proximal side where the filling is quite sensitive to any deformations or irregularities there. So I hope the question was answered. The next one from Sundar. Will I be giving a list of instruments to buy? I don't have a list by myself, but someone from the RIPE Global team, I'm sure they can post the link on chat of the instruments I was using in the online virtual hands-on course. So the list should be available somewhere. Candy is asking, sometimes I have trouble placing a V-ring because of where my rubber dam clamp is. Do you have any suggestions on how to overcome this? Yeah, that's a problem. Sometimes changing the rubber dam clamp to one that goes a bit deeper apically can help. Sometimes changing the rubber dam clamp. So I'm really a fan of 27N from Hoof Really. It's a nice clamp because it's very, how to say, has a very narrow profile, so it doesn't interrupt a lot around the tooth. So you can still place the ring in most situations. If possible, try to place the clamp more distally than you're working on. So if possible, if you have a defect between the 6 and the 7, place the ring on the third molar and you'll have all the space you need. Or just try changing the clamp. The worst situation, don't place the ring at all. Just adapt the matrix with a flowable or Teflon and just use good wedge to have the separation. Okay, what kind of brush do I use to make the cuspal anatomy? So this brush was from GC, and it's the only brush. I tried using quite a lot of brushes, but actually it's the only brush that really works well in my hands. It's quite cheap. You cannot autoclave it, but you can disinfect it. So it should be in the list somewhere in the chat or in the follow-up email. Someone from RIPE Global will provide you the exact details from the brush. Sundar is asking, our photos are from microscope. So in the presentation, what you've seen, all the pictures are from DSLR camera. So just a Nikon DSLR body, macro lens, and ring flash or dual flash. I can't really remember. I use both. Microscope pictures are not as good. However, the videos, the video you saw was from the microscope. So for the videos, obviously the scope is more convenient. Okay, this is a classic one from the anonymous attendee. What brand of composite I'm using? It depends. I've used a lot of different brands. The main idea is you have to choose the composite that is convenient for you to work with. If I would tell you what kind of composite I'm using and you would try it and you wouldn't like the handling, you won't get the same results. So currently I'm using Majesty AS2 Classic Shade Range. I'm using the Spectra from Dentsply. I used to use GC Essential Universal quite a lot. I tried some 3M composites as well, and actually I don't really see that much difference in the appearance of the composite, just some handling particularities. So you just choose whatever is more comfortable for you to work with. The question from Haitan Patel. The choice of composite I covered in the previous question, and the bonding. So for bonding, I have a very simple rule. I use SC Bond 2 for most of my fillings because I don't like to etch the dentin. So OptiBond FL is out of the question. The second gold standard adhesive is SC Bond 2. I quite like the handling. I know a lot of colleagues that were using the same bond for a long time and have good follow-ups and good results. So I'm just following their opinion. And if I have very small cavities, difficult access, or I need to be very fast, I choose anything from the universal bonds, again, depending on the handling. Another anonymous question, are there any special instruments that help you carve the anatomy? So yeah, you'll get the instrument list. Basically, the brush and the fine tip probe is all you need to have the nice anatomy. Dima is asking, what about teeth which are worn or big parts of them are gone, so there's little reference? So actually, that's where you have to remember the reference point. So like the middle of the wall, the 1/3, 2/3, whatever you think of, or whatever you follow what I teach in the borders technique, that will help you in the occlusal surface to navigate the occlusal surface. So if I'm doing a direct overlay, I just follow like the rough guidelines and just see how it goes. And of course, if the tooth is worn, try not to overbuild it. Sometimes the flat filling is the way to go as well. Okay, 4 questions from Sadia. Do I go through edge bond process before increment each time? No, I only edge bond the cavity once, and I just do incremental build-up technique, just whatever your composite and bond manufacturer would suggest as well. How do you hold the composite in place and not let it flow before curing? Well, it's choice of the material, I guess. There are some brands that are very soft composites that slump, so you should avoid it or you should work really fast. Will making a cusp from composite make it prone to fracture? Well, if we restore the cusp with the composite, I guess there's no way to avoid the fracture of the cusp unless we cover it with the indirect material. I wouldn't think that choice of material is the most important for the fracture. Can I kindly share the brand of composites I use with the instruments? So instruments are covered, brand of composites are covered as well. So let's go to another question. Do I think that glycerin can be used on top of composite as a last layer? Yes, I do this just before the polishing to get rid of the sticky layer or oxygen inhibited layer. Anonymous question, how do I make sure the fillings are not too high? Well, just following the idea of the borders technique, placing the increments where they should be and following the remaining tooth structure so I'm not overbuilding helps a lot, but sometimes happens and it's no way to be sure from every time. Okay, another question about the brush we already covered. Question from Shauna, do I coat my brush with anything? Yeah, I use modeling resin. The only secret to modeling resin is you have to use the modeling resin and not some kind of adhesive. And you have to use it like almost none of it, so you don't dilute your composite with the modeling resin. Dr. Priyanka asking, can I please help with the books for dental anatomy or dental composite? Not really. I had one book on waxing up natural posterior teeth. It was nice to look at the pictures. The text part I never went through because it was, I guess, too boring, honestly. So basically, better learn from nature. Pictures, models, whatever, it will be better for you when you work than just trying to read about it. Another question about composite material. Anonymous question about the polishing protocol. So the polishing protocol should be, if you already RIPE Global member, the theory part of the lecture is there, so the polishing is covered there, but basically any new two-step composite polishing systems give me a very nice gloss for my fillings. So I just remove the bulk with the burrs and then use two-steps polishers to achieve the gloss. Another question about the modeling resin. Yes. Another question from June. Those increments are all well-sized. Does your nurse roll the composite increments into little balls for you? No, actually I use the compules and I inject the composite most of the times directly into the cavity if I'm building a huge increment. If not, I just snap a little bit from the tip of the compule and this helps. Try not to roll anything with your fingers because the fingers are quite dirty. I usually change my gloves just before I start my bonding procedures. And even then you can incorporate a lot of dust particles in your composite increments. Question from Jack. If we go into lockdown again and can't work, what would you recommend practicing on? I've tried wax and plasticine, but it doesn't have the same feeling as composite. That's true. I would suggest you having, you can have some practice models. So these are easy. Extracted teeth, or just drill some denture teeth. So you have some teeth with the cavities inside, or you can actually drill some plaster models again. So you just follow with the anatomy. Or you get the virtual hands-on kit with the printed models, and use old composite. So whenever your composite expires, just don't throw it away, keep it in your drawer, and you can practice at home if we get into lockdown again. Another question about the brush, instruments, book and the course. So of course I can recommend my course. There are a lot of great clinicians you can follow as well. I've learned a lot from Stefan Brovet and Gianfranco Politano about layering and composite increments. So those two names I can highly recommend. Ripe Global, I hope to see some content from some of the teachers there as well that will help you with occlusal anatomy as well. I have a question from Meg about how we go about class 2 cavity restoration. That's, I guess, a question I would need another masterclass to answer. I think I might have a course about that pretty soon in Ripe Global. This is in the works, so it might answer there. I try to follow part of the idea from David Clark and the BioClear method, just to get you on track. Stephen is asking, am I working with warm composite through the procedure? And if so, what the temperature is? When I used stiffer materials, so the old Spectra or the ceramics, I used to heat it to 42 degrees just to make it more plastic. The new composites I'm currently using, they're quite soft, so I don't need to warm them up. Just for the proximal wall buildup, then I heat somewhere from 40 to 70 degrees whenever the heater is actually heated at that moment. Okay, some thanks messages. Jason is asking, how long do I cure each increment? Whatever your curing light and your composite manufacturer is asking for, do it. Don't cure less. You don't want any uncured composite in your occlusal surface unless you're working with the very miniature increments. And of course, you only need to cure them so they hold the shape. And whenever you end up curing all the occlusal surface at the end, you'll have those increments cured. But basically, it's better to light cure whatever your manufacturer is suggesting. Some questions about the instruments and the materials. Okay, Jason is asking, how do I work out the depth of the grooves and the height of the cusp? So the first layer of the dentin defines where my grooves will be and how much of the inclination of the cusp will have. So I go more in detail in the course. This helps a lot actually. And from there, it's basically just a feeling. So when I level up the cavity, you need to leave about 1.5 to 2 millimeters for your enamel layer, and this helps a lot. Another question about the heated composites. Dr. Manisha is asking, can we notify her about another masterclass? So I think the recording will be available. So someone from the Ripe Global will take care of that. Brush coating answered. Ahmed is asking, how can I have a reference point in terms of depth? So again, the leveling of the dentin, I just covered it a few questions before. The same questions, answer question from Ruta. The composite I used in the hands-on video, I cannot remember the capsule shade, so it was either Majesty or Spectra. Yeah, those two are my go-to now, usually. Question from Harsha, which composite and instruments I used. It's covered. Okay, Dr. Neha is asking, what is the purpose of the stain and the filling? Well, actually, just to make it look more natural, especially if the neighboring teeth have the stain. It's just nice touch. It gets some depth for the filling, which is also sometimes a desired thing to do. And the only clinical justification to putting the stain in, if you put the stain in and you have some irregularities in between your layers, you will see them. So you might catch some bubbles or bad layer adaptation. Otherwise, it's just purely artistic thing to do. Dr. Buna is asking about unfilled resin. I use the modeling resin for the brush. That's all I can give from the technical details. Curing time already answered. Dr. Atik is asking, can we use inlay wax for practicing in lab? Yes, it will be a good practice for you to work on your understanding of the anatomy, but it will be far from what you're working with here, the composite. So I would suggest working with the composite from the beginning, just so you have the same feel working with the composite and not composite and wax. They're different materials and different approach to carving those. Alina is asking, were I using bond on the brush? No, modeling resin, don't use the bond. There's a lot of stuff in the bond you don't want to use. Okay, some brush questions again. Instrument and material questions will be answered in the, I guess, in the different file or follow-up email. Dr. Harsh is asking, can we mold the composite after curing? Yes, a bit with the burrs, but it's not as nice as with the brush. The shapes are not as organic, and you'll have some scratch marks if using coarse burrs. So I prefer to model with the instruments and then adjust only where needed. Dr. Sukanya Telfer is asking what I do recommend for stains. So for the stains, go for a dark brown one, and the brushes, GC brushes, already answered. Dr. Gia is asking, how high do I build the dentin base? So I leave 1.5 2 millimeters till the cusp tip, pretty much. Marginal ridge should be at the same level as the marginal ridge of the neighboring tooth. Okay, these are answered. Again, some brush questions. Yeah, these are material questions, are almost always the most popular ones. Dr. Halima is asking about the ultraviolet rays for the composite filling. How many times do we have to use them? Again, follow your manufacturer instructions, both the curing light and the composite material. That's important. Anonymous question about how to save the anatomy during finishing and polishing. Well, if you put the anatomy in the right places and you don't overbuild, this should be quite good. Another anonymous question. What if patient has a treated teeth, the one I'm restoring, and even the opposite teeth? Do I still build up the anatomy or prefer, in this case, flat filling, so no high spots? Yes, if we don't have the space for the anatomy, don't build it because you'll have to grind it down. So you can rebuild the worn anatomy and just place flat increments and some minimal grooves in between. That's something I would do. Ahmed is asking, can I draw the anatomy from contralateral tooth if it's useful tip? What is your opinion? You would have to mirror it, so it's not very easy. If you have a rubber dam on, you won't see the contralateral tooth. So for me, it's easier to remember some reference points and go from there. Let me see, we have quite a lot of questions still. Annette is asking, do I cure each increment for 40 seconds? My composite I'm using lets me cure 10 seconds per layer. That's enough for me with my curing light. So if your light is older or the composite is not as sensitive for the light, then you might need to cure for 40 seconds. Just follow whatever manufacturer is recommending. Dr. Smith is asking, what are those two shades commonly used in posteriors by you? Good question. So I use very chromatic for the dentin. It could be SDR A3, Everix from GC, the dentin shade, any dark A4, A5, A6 shade for the dentin, and then A1, A2, or A3 for the occlusal layers. Simona is asking, do I plan a course for class 2 cavities? Yes, but the plans are difficult, so it will be someday for sure, maybe in the end of autumn. Let's see how it goes. Sonia is asking what solution I'm using for molding the composite. I guess I have answered this already. Okay, Gianmarco is asking what preoperative radiography factors would cause me to consider immediately using rubber dam. I'm not sure if I get the question completely, but if it depends on class 2 restorations. If I know it will be a subgingival restoration, I'll put the rubber dam from the beginning. If I see that the cavity might go deep under the gingiva, I won't put the rubber dam unless I see where my margin will be. I hope this answers the question. How do we clean the brush after use? I just soak it and then clean with the alcohol. If you have strict hygiene regulations, you have to check whether you can use the brush more than once, or is it a single-use thing. So just follow your regular local regulations. And the same question again. Some questions were already answered. Okay, Dr. Suda is asking about color and shade selection for the occlusal surface. I only select the brightness of the composite. So basically A2 and A3 cover like 90% of the cases. Another question about the polishing. Some tips for class 2, class 5 fillings. Well, I guess I would need a bit more specific question here. Okay, while I'm looking through the questions, I guess I'll just flick through the ones I already answered, so I would have the list only of the new ones. While I do so, maybe Dr. Rohit or Dr. Lisa have some questions after actually taking the hands-on course, or just have some insights so the other possible participants can learn from it. I would be happy to do the discussion live if you feel like it.
Hi there, you're right.
Hey.
Oh no, all I know is like, I think from what I was doing, when I first started doing like cuspal build-ups, or trying it, or seeing it on other courses, you know, I was trying to build cusp by cusp. I was doing exactly what Mindigos was saying about everything was converging to that midline. And I do this like, what I thought looked really nice. And then you check the bite and it's like, and you realize your cusps are high in the wrong places. And it's funny that doing the course, and then I didn't instantly follow the lessons. I was still rattling through doing what I did because just because of time and doing something new. And then I was finding that when I was checking the occlusion, I was like, right, that makes sense now, because now I've just seen those lectures and now I know why those points are hitting. I want them drilling back everything again, which is frustrating. So there were little things like that which really made sense. And then as you kind of then installed where those central lobes go, and then you suddenly realize you're not hitting those points anymore. And that for me was something that's really, I never really knew about, because I was basing a lot of my customer build-up knowledge on like watching Facebook posts and Instagram videos. And I think it's a commonplace. I think it's like you see like a quick sped up video on social media and you're like, oh, that looks pretty straightforward.
That's easy.
Yeah.
Okay. Lisa, any questions from you?
No questions. I just say that the course was really good. It was really straightforward, easy to follow. I know that I've never done a virtual hands-on course before, so I was a bit apprehensive kind of going into it. I've done a lot of Lincoln's hands-on courses, and so I didn't know how it would end up being, but during lockdown for Australia anyway, for us, like it was really good to have some time to kind of sit down and do it. And watching you do it is a work of art. It's you make it look so simple, and then trying it out is a bit of a different story. But like you said, with practice, it just slowly gets a little bit better. And although I haven't utilized getting secondary anatomy in there, making it look beautiful, it's definitely made my fillings a lot smoother, like going from not necessarily flat, but like Rohit going before me, you kind of mentioned everything already. Fillings that kind of look like teeth, but there was just something odd about them, and then just becoming kind of slowly more looking like teeth with the proper, like you said, just like proper shaping, like the mesiobuccal cusp of the upper molars, just having that bean shape. Like that was my wow moment. I'm like, oh, that makes so much sense. Little tips and things like that, and a lot of practice just makes it a lot more practical and putting it into clinical work. And definitely my adjustment time has gone down a lot, and I'm a lot more proud of my work, and it makes me feel more fulfilled. And I'm sure anyone who does good dentistry and strives to do good dentistry would feel the same after looking at their work improve really quickly, just like that. Yeah. So thank you. It's a really lovely course to attend. Yeah.
I was just going to say, like, the other thing I thought was like, it's really interesting having an order to build your cusps in, and having a plan also helps. Yeah, because I was kind of mindlessly just going like, oh, I think I want to start with this one just because, and there was no reason to it. It was just because I thought that would make sense. And then finally I ran out of space as I kind of going round in certain areas. So we didn't work out. You started with either like, oh, it's looking good, oh no, it looks awful. and that was the problem. So, but having like that whole kind of, if you fail to plan, you plan to fail kind of thing. So, but actually then watching your videos and then seeing that kind of, maybe just take this kind of ordered approach and work down that list and work in this kind of order, and then things kind of follow and kind of nest into place. And that really helped as well.
Cool. Yeah, so thanks for the feedback. I just looked through the remaining questions. Most of them are quite technical, so I guess no really the questions from the virtual hands-on. So I guess we can lay off Rohit and Lisa so they can carry on with your evening. But thanks for joining, and thanks for sharing your feedback. That's quite valuable for me, and I'm happy it helps you in your daily practice. And I'll just continue with the questions now. So Dr. Priyanka is asking, should we practice carving? Yeah, basically, I try to look at the modeling more from the additive perspective. Carving is more like removing the composite after actually curing it. So it's not really my approach, but if it helps you understand the occlusal filling, well, that's great. Practice carving, whatever helps you understand the occlusal surface better. Maisa is asking, yes, about curing the composite increments. So I was curing the increments in the video just for a few seconds, because that's how long I need to for the composite just to hold shape. So you don't have to look at a video of me curing the increments for 20 seconds. That wouldn't make any sense. So basically, cure your composite increments as long as the manufacturer of both composite and the curing unit is asking you for. Don't try to cure too little, because you might end up with some problems. Dr. Bean is asking, how much pressure do I apply when making the increments? So I try to inject the composite so it already hits the remaining cavity wall, so I don't have to pack a lot. And for shaping, I don't know, enough pressure for the brush to shape the increment would be my answer. I don't really have the metrics here. Good question from Vino is, do I take any articulating points before starting? That's a good idea, especially at the beginning, while you don't feel your composite increments well enough. When you take the bite beforehand, you can anticipate how much space you have for your composite filling. So for example, if you have an old filling that is already very deep and you have a contact point already there, don't build any anatomy, make the new filling exactly at the same place, unless you want to spend half an hour grinding your beautifully carved composite. So it's a good thing to practice. Usually I just eyeball all of the anatomies, but maybe it just comes with a lot of practice. Dr. Vin is worrying about air bubbles. It's always a problem, especially if you have an air bubble near the dentin. You might have some sensitivity, but if you inject softer composite or heated composite inside the cavity, and if you add a bit of flow before, you shouldn't have any voids. Charles is asking any tips regarding how to establish the occlusal height when I do quadrant dentistry. Well, basically, if I have the cusp tips are the highest points, so just you have to make the inclinations toward the center, and that's it, and just then adjust. If you don't have any reference points, like if you're making a quadrant of direct onlays, there's some techniques where you take stamps with the silicone before removing the cusp, so you have the reference points there. Or maybe if you're doing something as extensive as this, maybe it's a good idea to have study models to or just transfer the backs up to the teeth, so you have more precision there. Bianca is asking, how do I make sure I don't get voids? So you saw in the video, I use the microscope for my patients as well. So using high magnification kind of helps me anticipate whether I have voids or not. Using softer or heated composite helps as well. In deeper parts, flowable beforehand, so flowable fill the void. And I try not to pack back and forth very sticky composite, because then you can remove the composite from the walls and have the void there. So a composite of choice also makes sense here, so you have better adaptation. Gia is asking about full coverage buildup. What reference points do I use? So again, depending on the tooth, I have some reference points, like for the lower second molar we were talking about. So the middle of each of the surface and the center is all the reference points you need to rebuild the occlusal surface. As far as the cusp tips go, I just look at the arch from the side and try to put my cusp tips in the same line the other teeth has the position, so it follows the same arch shape and curve. Dr. Vin is asking about air bubbles and the pressure on the increment. So again, soft composite, slight adaptation. If you feel better by packing a lot, with the packing you can again remove some composite from the walls and have the voids there. It's also not too good. Tips for building up when whole cusp and walls around it are missing. Do you build the external wall and then the cusp? Sometimes, depends on situation. Sometimes it's helpful to create yourself an easy reference point. So for me, it would be creating a cusp tip. Just take low viscosity flowable or just a piece of composite, place it in your cavity where you imagine your cusp tip should be. Again, look at the neighboring teeth, try to make it in the same line, cure it, and here you go, you have a reference point where your cusp tip should be. From the cusp tip, you can add on the outer axial wall to recreate the wall of the tooth, and then continue the classic class 1 build-up technique. Dr. Shadi, I guess, asking about the right dentin and enamel shade and how thick do you place them. Dentin, just to level up the cavity, I use chromatic dentin. Don't use very chromatic dentin for very bright teeth because you'll have a dark spot, but most of my patients have posterior tooth shades in between A2 and A1, so dark dentin works really well. As far as the enamel shade goes, it's any body kind of mass, universal kind of composite. A1, A2, and A3 pretty much covers all your filling needs in the posterior region. Anonymous question about my favorite flowable resin for aesthetic areas, class 5s or resin veneers. I guess I would choose something that can be used in the occlusal surface, so it has a high wear rate. So anything from the new composites, I think GC has injectable that's supposed to hold well in the occlusal surface. Curare has the new flowables that are pretty tough as well. So I think I would go with those two brands. Dr. Nadini is asking about MOD cavity and still destroyed fillings. I sometimes lose the anatomy on marginal ridges. What do I do then? This is a very common mistake when you take a matrix that is too high, and that's why you use that's why you lose the marginal ridges, because you overbuild the cavity, and when you have to adjust, you remove the marginal ridge too much. So try using smaller matrices and try to look at the neighbor and recreate a marginal ridge at the exact same place where the neighboring marginal ridge is. Wayne is asking, how do I build mesial or distal walls if there is extensive loss of tooth structure and you're unable to use the G-clamp? Again, if you cannot use the clamp, use a different matrix fixing material. Sometimes you can even use the Toffelmeyer with the curled bands, or some saddle matrices with the special holders if you cannot put on the clamp. And if you need separation, use wooden wedges for that. Dr. Halima is asking about seriously decayed cavity. Can we use composite filling? Sometimes we have some rules when we can go direct and indirect, but sometimes we have to abandon the rules for some socio-economical interests of the patient. So sometimes I do direct crowns or direct onlays, and some of those work surprisingly well. But if we need a crown, the patient should know that he should get a crown and make the choice. Anonymous question about magnification. The loops, in my opinion, loops are mandatory, I guess, for dentistry, or magnification is very helpful for everyone. I would start at 4.5, 4.5 magnification, 4.5 times magnification. I guess it should be a very good starting point for everyone. If you can get a scope, then get a scope. When I switched from the loops to the scope, I barely use loops anymore. So have happy working with the loops, hopefully. Basma is asking about the type of light cured unit, I guess I used. So it was just a GC light I got with the composite. I guess use whatever is helpful for you. I didn't dug up much about the science on the light curing and whether it affects the end result too much or not. Justin is asking about body or enamel composite for the upper layer. Yes, that's a good question. I don't use the enamel, very translucent enamel mask for the occlusal layer because I like to have thicker layers there. So I don't want my filling to look gray. I use body or universal shades for that. Lucia is asking, do I always cure flowable and dentin layer together or sometimes separately? Yes, sometimes if in very deep cavities, I would use just a flowable to cure with my bond layer to reinforce the bond layer. In more shallow cavities, I might cure them completely. Sometimes I would use just a bulk fill flowable to level out the cavity in the deeper, larger fillings, just to compensate for the stress of the polymerization. So it depends really on the materials you're using, but both options are possible. I wouldn't use them together if the cavity is very huge and the layer is very high, because I am afraid I won't cure in the deeper parts well enough. Chris is asking, do I use different techniques or materials for bruxers? No, because I guess we won't cure the bruxing with the material. So if the patient will wear the teeth, pretty much all composites will wear very similar. So if you want to save them from wear, I guess you need to have a night guard or try to find the cause for bruxing and maybe improve it. But I don't think the material will make it better. Julie is asking, do I routinely fill the entire pulpal floor with a single layer of composite? Do you ever have concerns about the shrinkage? Yes, if I have a very deep cavity and a very huge one, I would choose the bulk fill material that has less polymerization stress. If I would still need to use the packable composite, I would layer incrementally. Since the demo video is on plastic tooth, it's just for referencing the idea of what the shape of the dentin should be there instead of the exact technique. Ibrahim is asking about the drawbacks of the layering technique. So, well, basically with the layers, you can introduce voids and air bubbles. I guess that's the main drawback. So just injection molding or monolithic composite might be a bit stronger, but then you won't be able to control the occlusal anatomy well enough. So every technique has some advantages and disadvantages, I guess. Anonymous question about the stains. When do we put them? I put the stains as the last layer, just because I have the best control on it. If I would use the stain while some of the composite is still soft, it's very easy to influence the shape of the remaining composite layer that was not cured while removing the stain. What burrs I'm using to grind the high points, basically football shaped or ball shaped red ring diamond burrs are my usual burrs, and then I really try to polish off the burr marks if there are any before final polishing. This one I answered already. Harsha is asking, till what time can we mold the composite? Yeah, so depending on the light source you're using and the composite brand you're using, some composites let you do the filling in, I don't know, 30 seconds to 2 minutes or even more. So it really depends. Usually I find that having 1 or 2 minutes is enough for one composite increment with the materials I'm using. Sam is using, do I use occlusal stamp at all? I did before, but then I understood that from the technique itself, I don't learn a lot myself. Sometimes you can get a very good result, but sometimes you end up with the filling that's a bit too high, or the time to remove the excess material takes too long compared to the traditional layering. So I just, at one moment, I decided that I'll stop doing stamps unless the situation really asks for it. So I have a very nice occlusal anatomy and the filling is very small, then I will go for stamp. Otherwise, I'll try to rebuild it everything freehand so I can really get some practice in anatomy buildup. Shade selection is basically, I just look at the value of the tooth and I try to choose the right shades depending on the value. So older patients, darker teeth, A3, A3.5, younger patients, somewhere in between, A2 maybe. I just look at, I barely use the shaded tabs anymore, honestly. Halima is asking about the base with silver. I'm not sure I have any experience with these materials, so I have no answer here. Nuha is asking about the brand of brand of wetting agent. So I use the one from GC Modeling Liquid, I guess it's called. And Kurari is also having, has a product for modeling resin as well, but I don't remember the name. Books already covered. Lucia is asking, why do I put the wooden wedges interproximally before cavity prep? Well, just so I have some papilla depression and some separation while prepping. Sometimes it helps. Okay, Sas is asking to clarify, would I place the rubber dam if the cavity would be subgingival? No, I would prep before, see how deep subgingival is and whether I can put the rubber dam on till the same level, or I need to adjust the papilla for that, or maybe do some periosurgery for that, and only then put the rubber dam on. You don't want to struggle with the rubber dam and then prep the cavity, end up with the gap between the rubber dam and the cavity. So always prep, then rubber dam, unless I'm sure the restoration will be supragingival. I hope this is more clear. Ibrahim is asking how to deal with teeth that have some sort of weird anatomy. There are definitely some teeth that don't follow the rules. However, if you have the same idea for all the teeth, so you just follow the remaining tooth structure and just try to recreate whatever there was before, it should be the result you're looking for. Just follow the nature. Anonymous question. Did I say that building these anatomy increases risk of fracture? If so, do you still attempt to do so in most cases, or only if patient is highly conscious of aesthetics? Just to clarify, the question was whether building the cusp slopes in the composite will have a risk of fracture. So I said that the material of choice won't influence the fracture that much. So we're just recreating the part of the tooth. So if we have indications for direct restoration, the choice of the material is composite, and that's what we're using. If we need something stronger, then maybe we should be looking at the indirect restoration. So I haven't seen any cusps fracture from the composite cusp or fracture in between. Maybe some thin overlaying composite resin layers, bonded or not bonded well enough to the remaining tooth structure might chip off, but they're easily polished on the follow-up appointments. Wayne is asking, can we use bulk fill for the whole restoration? If you're using the bulk fill that is developed for it and the manufacturer is allowing for it, then yes. But regarding the control of the occlusal surface, I find it quite hard with the bulk fills, honestly. Sonia is asking, in case of sensitivity, do I recommend use of the sensitizers? If yes, which is the material of choice? If we're talking about post-operative sensitivity, then I don't really have the same problem in my practice. So I guess having a dry field and a good bonding protocol solves all the problems here. If you have some, I don't know, recessions or open necks of the teeth and you want to solve those, there are some materials to desensitize them. Most of them work pretty well. And the last question, will this course be appropriate for a second-year dental student? It's really a tricky question. It will definitely help you understand the anatomy better. You'll have some skills practicing the occlusal buildups. It might help you in your preclinical works and when you start working. So I guess it depends what you want to learn. It can be a good thing to do if you have the means to take the course. Then I would be happy if you do, and then give me your feedback. How do you feel as a second-year student? In some of my live courses, I had some older year students, and most of them felt some improvement, because usually in most of the dental schools, the occlusal stratifications don't take too long time to master for the students, or the students kind of don't yet know what kind of layering techniques they will need in the future, so they don't look at the subject as serious as they should, maybe. Or at least I feel so, that when I was a student, I hope now that I learned the occlusal anatomy better, because then I had some problems when I started work, when I didn't really know how the tooth should look like, or what are the reference points that will help me. Okay, and so this was my last question. So I guess I would like to thank all of you again for joining us. If you get the virtual hands-on course and you'll have any questions, then you will be able to join the Facebook group where I give the supports for the participants, and we can discuss further. And yeah, a few more questions. What would be the best mode of communication with you for feedback and advice? So either virtual hands-on course and the support group in the Facebook, or if you have just a small question, some technical detail you want to solve or clarify, you can just try and contact me on Facebook or Instagram, and I'll be happy to help. So thank you all for joining us today, and I hope to see you soon again, maybe for another masterclass. Have a nice day or evening, depending on which part of the world you are now.